Hello, welcome to this presentation on newborn neonatal resuscitation. My name is Dwayne Howerton, and it's a privilege to bring you this information today. So what happens to us whenever we get called out for a pregnancy with imminent delivery or childbirth with complications? I'm sure our heart rates go up a little bit. We get a little bit of adrenaline flowing, some excitement about the situation we may be walking into, because definitely there is a lot of unknowns there. And some of this may be anxiety as well. It has our heart rate up because this is something that we don't deal with often. So understanding that 90% of all deliveries are uncomplicated and really require only minimal intervention on our part to get the newborn going, that's comforting. But what about this other 10%? In most cases, they only require some warming, a little bit of stimulation, and even maybe a little help breathing. But there are a few that require us to go just a little bit further. That's what we're going to talk through today. So these high acuity, low opportunity events, really require your expertise, your precision, and a high level of team dynamics. But here, before we get started, let's dive through a few formalities. So I have no disclosures to make as it relates to conflicts of interest or financial investment related to this presentation. There's no descriptions of off-label use within this presentation as well. So what are our objectives? We want to identify the newborns who require resuscitation. We will discuss those initial steps that need to be taken. We'll define the findings of an improving newborn due to our resuscitative measures, and then we'll discuss some ongoing resuscitative efforts if required. When events of resuscitation are required, we often have little to no time to anticipate these events because there's little history taking that can take place. We don't have the prenatal records to review and the like. So most cases that we'll be walking into, usually just the first responders handing us the baby, or the baby's just about delivered upon our arrival, or the parents hand us the baby. So here are three things that can get us through this situation. And that's going to be our goals, some focus, and preparation. So what are your goals in achieving a good outcome? There's really only three. That is warm, pink, and sweet. And pretty much in that order. Efforts we will discuss here soon will address the steps to achieve these goals, but it's important to remember that there's a high mortality and morbidity rate with cold newborns. So warming definitely is going to come first. So that transitions us into what should be our focus. And so our focus based on our three goals are going to be obviously warming again, as this is a key to our success. Unlike adult resuscitation, where circulation and chest compressions come first, in newborns it truly is A, B, C, as the majority of circulation issues are going to be addressed through effective management of airway and breathing. So to this point, your education, training, and experience have really prepared you to respond to this situation at hand. And it's time for us to prepare ourselves kind of emotionally to get in the game. So, self-breathing, positive self-talk, visualization, recalling what you learned here today will be important. Also, having your team prepared to respond to this event is important as well. So talking with your partner on the way to the call, on scene with the FRO, communication is going to be key. Delegation will be important. Instructions need to be clear and concise, and we definitely would encourage out loud thinking. When preparing your gear, obviously you checked everything out at the beginning of the shift to make sure everything was on your ambulance, on your fire truck, all the necessary equipment was present. And thinking about our goals that we want to accomplish in that warm, pink and sweet. Warmth, we have blankets, towels, even a plastic bag that will be utilized. Airway, we have our suction, we have bulb suction. Breathing, you have your BVM, your O2 mask, you have your VL device, your endotracheal tubes, your supraglottics. Pink, it's just going to take a touch of O2 to achieve that. And then circulation, you have your IO, your IVs, you have some epi in the bag, and fluid. And to keep them sweet, well, you got that D10 to do that. So, how do we prepare the patient? I think the big thing here is going to be your confidence in telling mom that we've got this. You know, your experience, your training, your education, going through this program today will help build your confidence in your actions and your presentation towards the resuscitation will go a long way in reassuring a mom. So who needs to be resuscitated? So let's answer that with the 3 questions that are involved in neonatal resuscitation. That's going to be, is the baby term? What is the baby's tone? Or is the tone good? Is the baby breathing or crying? So term, good tone, breathing or crying. Those are the first 3 things that we want to know. And those are the first items in the box here. So let's answer that. So in some situations, the baby's gestational age may not be known before birth. And if you're able to catch this instance before birth and you're able to measure fundal height, you know, you can use that distance between the pubic bone and the fundus to estimate the gestational age. Understand that this is accurate within 1 to 2 weeks as long as the fundus is at the umbilicus. So at that point, when the fundus is at the umbilicus, you're looking at the mom to be about 20 weeks gestation. And every centimeter above that, you can increase that gestational age by that amount. So if you're say 5 centimeters above the umbilicus, you're looking at being somewhere around 25 weeks. So you could say that, you know, maybe 23 to 27 weeks there. So that's fairly accurate. Using the last menstrual period really doesn't get you a gestational age. It kind of tell you, you know, how close you are to the due date. So you take that last menstrual period, you subtract 3 months, you add 7 days in 1 year, and that'll get you estimated date of delivery. Viability is important because we don't expect, you know, these prenatal, the super preemies less than 20 weeks to survive. And so consideration of the use of your withholding of resuscitation if the newborn is less than 20 weeks may be the most prudent treatment. Obviously, up at 23 weeks gestation, the survivability climbs exponentially, and so we definitely want to put forward some effort in resuscitating those. You know, preterm babies are definitely going to be more likely to require interventions. You know, we're talking those less than 37 weeks are considered preterm. So that transition to uterine life is going to require us to intervene at some level. You know, they have some difficulty in expanding their lungs, establishing a good respiratory effort, and maintaining their body temperature. So because of these risks, we definitely need to be on alert to take these steps in newborn neonatal resuscitation. So good tone, what does that look like? So a healthy baby or a healthy term baby, their tone is going to be, you know, extremities are very active and their extremities are going to be flexed. Newborns that are going to require some intervention are going to present flaccid. Their extremities are going to be extended, and there isn't going to be a whole lot of motor movement going on. So I think you can almost audibly hear these pictures as we were assessing breathing or crying. And, you know, if a newborn's not busting your eardrums, it definitely needs some further investigation in conjunction with, you know, if they were preterm, then have poor tone, they're obviously going to need some assistance in transitioning to this extrauterine life. Your APGAR is something you're going to collect at the 1 minute mark. It does have some information that will kind of help you in guiding whether or not resuscitation is going to be required. And just by answering your first 3 questions, you've gathered all but one of the scoring points on the APGAR scale. So you'll be able to get their appearance, obviously. The pulse rate you won't be capturing at this point in your evaluation and your resuscitation efforts. But grimace, obviously, you can tell if they're crying or not, if that cry is strong. Activity, obviously, you can tell that by your tone. And then respiratory effort, again, evaluating the cry of the baby will give you that information. So what are we looking to get done here in this first minute after birth as you're assessing the baby and determining if resuscitation is going to be necessary? Obviously, the answers to your three questions are going to help guide that and lead you into your next steps. So if the answer is yes to all three questions, then you're one of the lucky ones, or one of the common ones, I should say, in that you have one of the 90% cases on your hands. And really, most of the work's already been done, and you're not going to be required to do a whole lot more other than, get the baby dry, make sure the airway's positioned well, and get them on mom's chest, and everything else will take care of itself. But if that answer is no to any of the three questions, then obviously you have some more investigation to do. You're going to have one of those 10% cases on your hands, and we've got to get a few things started. So let's dive into that. So your priorities are going to be here to make sure that the baby is warm, all right? And then position that airway and stimulate. Now, temperature management is going to be important, as we previously mentioned. Avoiding hypothermia at all costs is important because it's associated with increased mortality and intraventricular hemorrhage, along with some respiratory complications, hypoglycemia, and even late onset sepsis with these kids. So your target temperature is going to be that 36.5 to 37.5 degrees Celsius axillary, and that's where we want to keep them. So to achieve this, obviously, if they are greater than 32 weeks gestation and they got good tone and they got a good cry, we want to use just the drying method, a towel, get them dried off really well, and then get them skin to skin with mom, as that heat exchange will definitely help keep them warm. If you're in the back of the ambulance, just make sure your heater's on and keep that environment warm. If you're dealing with a less than or equal to 32-week gestation infant, something interesting is just best to place that infant wet, not dry, wet, into your plastic bag with their neck out and head out of the bag, and then wrap that with a towel, and this will actually keep them quite warm. So active drying with a towel at this age can cause skin tears because their skin is very fragile. So we definitely don't want to be actively drying these less than 32 weekers. Again, that warm environment, so the heater on in the back of the ambulance can be vital in assisting you in that temperature management. Next, we want to just assure the airway is patent. Now, previously, we suctioned like everything when these newborns or when these kids were born. So routine suctioning of secretions or even meconium is no longer recommended unless it's just an overt airway obstruction. So just have your bulb syringe handy. It may come into play later and you might need it. To stimulate, all we need to do is just rub the back or assertively flick the heels of the feet. Nothing like these old pictures of, the black and white pictures of babies hanging upside down from their feet and doctors spanking them on the butt. Now we just need to wrap them in a towel, aggressively, rub their backs and things like that. And, just that simple drying action of that greater than 32 weeker is enough stimulation to get them going. And of course, to optimize breathing through a patent airway, it may be necessary to position the baby in that sniffing position, and we'll discuss that next. So to achieve this optimal sniffing position, we just simply place a towel roll under the newborn's shoulders to get that forehead and chin to align in a parallel plane with the body. It'll produce a wide open neck area, and it'll actually, by doing this, we'll actually place the patient in that ear to sternal notch that you've heard us harp on in so many other CEs. So support under head may also be required, maybe a pillow to help support that head, but this will put you in your optimal patent airway position. So, breathing is our next priority, hashtag ventilation. So heart rate is directly tied to ventilation effectiveness. And you notice there, I didn't say oxygenation. We'll address that later on. But at this point, we want to now assess the heart rate. So we're warming, we're stimulating, we're drying. If necessary, we have the baby in a bag to help keep it warm. And we have a patent airway. Now we want to assess the heart rate because this is going to tell us the next steps that we need to take. So if the infant, you know, has no labored breathing, heart rate's greater than 100, and of course everything is great. But what if the heart rate is greater than 100, but we have this labored breathing or some persistent cyanosis? What are some things that we need to do? So big thing here will be to reposition the airway, make sure that it's clear. We don't have an obstruction that needs to be suctioned. Use that jaw thrust technique to help lift the tongue off the back of the throat. We want to place an SpO2 monitor to help guide our resuscitation on the right hand. And again, I want to say the right hand and right wrist. This is where we'll be able to measure pre-ductal oxygen. Now, not getting into an A&P lecture here, just understand that it needs to be placed on the right hand, and that will capture that pre-ductal saturation for you. This is blood that isn't going to be mixed with the blood that would naturally go through the ductus arteriosus that still may be open. That blood is flowing actually to the left hand. So again, SpO2 monitor, right hand, that'll give us a pre-ductal oxygen saturation, and we'll talk about those numbers here in just a minute. You may need to apply some supplemental O2. We don't want to blow that directly into the baby's face. Definitely blow by is important there, and not at full blast, of course. Consider positive pressure ventilation if necessary, and we want to give us to get us a good heart rate. Placing a 3-lead EKG is the most optimal way to achieve that. There are several other ways that you can get heart rate that we'll talk about next, but a 3-lead EKG is optimal. If the neonate is apneic or gasping or has a heart rate less than 100, obviously we're going to intervene, and we're going to intervene with positive pressure ventilation. In addition to making sure the airway's open, we got that SpO2 monitor on, jaw thrust, all those necessary things. And our target breath rate is going to be 40 breaths per minute of effective ventilation. So effective ventilation is, with positive pressure, is going to be a nice puff that generates enough pressure to just cause the chest to rise. We're not giving the full bag squeeze, just puffs that allow the chest to rise or cause the chest to rise are going to be your effective ventilation. So how are we going to measure the heart rate? We mentioned this earlier. There's several ways, with the 3-lead placement going to be optimal. You can auscultate the heart rate with a stethoscope. You can also palpate the heart rate at the base of the umbilical cord. But obtaining an accurate heart rate measurement is of utmost importance, as it helps guide our resuscitation. It kind of tells us how we're doing as it relates to ventilation. And it's the most sensitive indicator of adequate resuscitation and reflects adequate ventilation and oxygenation. So that 3-lead placement as described there in the picture is going to be your most optimal capture of heart rate. So when we talk about ventilation here, that we're providing positive pressure ventilation, we want to make sure that that mask fits well over the bridge of the nose to the chin. This will minimize our air leaks. We need to ensure an open mouth using that jaw thrust and minimize the pressure on the neck, as this will avoid, pushing the tongue back on the throat and causing an obstruction. 2-person technique is preferred. It's something we practice in adults and children already. And avoid overventilation while bagging. You just want to apply enough pressure to the bag to cause adequate chest rise. Or if you have an anemometer on there, and you can measure those pressures, those peak inspiratory pressures, it's going to be about 20 centimeters of water. So some pitfalls with bagging is that if we do overbag, we give too high of a tidal volume with little extra squeeze, that this can lead to a pneumothorax that will impede further resuscitation, and can also cause a pneumomediastinum. And these things are common. So we definitely want to avoid overbagging by applying just enough pressure to cause that chest to rise, or that peak inspiratory pressure of 20. And we're looking to provide about 40 to 60 breaths a minute, so about a breath per second. So the next 30 seconds we're going to spend on effective ventilation, and we're going to use this ventilation to help us increase the heart rate, or reduce the cyanosis that we're finding. So earlier, remember, we talked about that preductal saturation. And ventilation here is more important than oxygenation, as it takes about 10 minutes for babies to achieve a normal oxygen saturation level. So we're not really too concerned about the oxygenation just yet. So here we have a chart that gives us some targets within minutes of birth. So at a minute of birth, you're looking at O2 saturation of 60 to 65%. So don't be alarmed at that point. Your expectation is going to be that this is going to increase over your time in resuscitation. And at the 10-minute mark, you should be up in close to 95% with your oxygen saturation. Again, O2 sat probe on the right hand or right wrist so that you get an accurate measurement. For the term and late preterm newborns, and those late preterm newborns are going to be that greater than 35 weeks, receiving this respiratory support, we want to start them out on 21%. So just room air is all they need, and that's reasonable to assist you in your resuscitation. Now, preterm newborns that less than 35 weeks that are receiving this respiratory support, may be reasonable to begin with 21%, but you may need to go up based on their oximetry, so as you progress through this resuscitation and you hit these minute markers, and are they in range of this O2 saturation? And as you can kind of see there, we're starting at 60 and we're kind of increasing by increments of 5 with every minute. So 60 plus 5 and you should be good to go. There isn't really any reason to really provide 100% FiO2 to these kids, and it's really not necessary, but in our situation, we don't have air blenders to be able to provide the different levels of O2%. So effective ventilation will translate into end-tidal CO2 waveform, which you should have on your BVM. And the biggest indicator of effective ventilation is also going to be increasing heart rate. So these are the goals with effective ventilation. It's going to be increasing the heart rate. So after 30 seconds of ventilation, if don't have an effective improvement in our clinical status, the heart rate's not coming up, there's a little mnemonic called Mr. SOPA. And this is in an effort to help us correct our ventilations and to provide more effective ventilations to the baby. So mask adjustment, reposition the airway, make sure that you're in that good sniffing position, suction the nares if they are obstructed, open the mouth, make sure the mouth is open during our ventilations. May need to add a little PEEP to this, to your BVM, and provide 6 to 8 of PEEP, because we're trying to get those alveoli to open up and stay open. Also, maybe consideration of an advanced airway if you see that you're providing effective ventilation or having some difficulty there. Proceeding with advanced airway may be an important step. So, ongoing resuscitation efforts. Well, is it time for chest compressions? Well, not just yet. So after 30 seconds of positive pressure ventilation, we want to reassess our heart rate. And if the heart rate is greater than 100, we want to continue with this positive pressure ventilation at a rate of 40 to 60 if there is no spontaneous effort. So we definitely want to assess the respiratory effort of the newborn at this point with a heart rate greater than 100. If that heart rate is still less than 100, we're going to continue with positive pressure ventilation, okay? If the heart rate is less than 60, we want to establish adequate ventilation before beginning chest compressions. That's right, before beginning chest compressions, we want to assure that we have adequate ventilation. And this may mean securing an advanced airway and initiating positive pressure ventilation that way. But it is strongly recommended before starting chest compressions that we assure that we have adequate ventilation in place. So our goal here is to establish this advanced airway in less than 40 seconds. We don't want delays in this because this increases morbidity and mortality. Strongly consider using a supraglottic airway rather than BVM and endotracheal intubation in neonates that are greater than 34 weeks gestation and greater than 1.5 kilos. There was a Cochrane review in 2018 that found that supraglottics demonstrated comparable efficacy to endotracheal intubation. So when compared to BVM, supraglottics was associated with a shorter resuscitation and ventilation times and less requirement for endotracheal intubation. So, but there are some caveats with supraglottics. The size of the infant, less than 34 weeks, less than 1.5 kilos. They're just not a supraglottic that's small enough to address those super tiny neonates. And then there really hasn't been any evidence for giving epinephrine down a supraglottic airway should that be required. And then it's unclear if asynchronous chest compressions can be given with supraglottic airways. Some of the pitfalls that I think we even see these in adults is that if we insert the supraglottic too far, then the ports that the ventilation comes out of on the supraglottic is down in the esophagus, or we've obstructed the airway with folding the epiglottis over the top of the trachea. And then also, there's potential for the supraglottic to kind of fold back on itself, and thus gas exchange isn't that effective. So just knowing those pitfalls is going to be important, not only in neonate and newborn resuscitation, but also in adult resuscitation as well. So what's preferred, video or direct laryngoscopy? And video laryngoscopy has been associated with improved success in tracheal intubation and decreased risk of complications in neonates compared to direct laryngoscopy. So we have the blade sizes. Term infants are going to require a size 1. Preterm infants, you have your size 0. Your ET tube range for less than 1 kilo is going to be a 2.5, and then progress up to a 4 for those greater than 3 kilo. Depth, you're looking about 6 centimeters plus the weight in kilograms. And obviously with VL and the marker on the ET tube, you should be able to see when that passes the cords. That's as deep as that you need, the deepest you need to go. So what about the next 60 seconds here? What do we got going on? So after ensuring adequate ventilation is established and remembering to secure that advanced airway and initiating positive pressure ventilation, we can now think about chest compressions. So if the heart rate remains below 60, after we've done all this work with the airway, then it's time to begin compressing the chest. We're going to use the 2-thumb technique over the lower 1/3 of the sternum. Going to compress about a depth of 1/3 the chest diameter. And ideally, this is kind of done from the head of the bed. And definitely it's preferred over the 2-finger method for chest compression. So the 2-thumb method is definitely preferred. We're going to do this as a rate of 3-to-1 coordinated with our positive pressure ventilation. So we're going to have about 90 compressions to 30 ventilations every minute. And so this equates out to about 120 events per minute. And so to accomplish that, you can kind of follow the rhythm of 1 and 2 and 3 and breathe. And this will get you to that 120 events per minute. So at the 60-second mark, that's when we'll do our pulse checks. And definitely at this point, we can begin to consider intravenous access or IO access. So interosseous access is only suitable for those term infants greater than 3 kilos. They require a more caudal approach than the older children, and immediate anchoring given that the bone cortex is quite thin in neonates. So after a round or so of chest compressions and there's been no change, what are we talking about next? So another 90 seconds here has gone by. So if the heart rate remains less than 60 after 90 seconds of effective positive pressure ventilation and 60 seconds of chest compressions, this is when we can add epinephrine. We'll also consider hypovolemia and also consider the potential for pneumothorax. So your epinephrine dose in neonate resuscitation is going to be drawn up in a 1 ml syringe. It's 0.01 milligrams per kilo, or that's 0.1 milliliters per kilo. Your first dose can be shot down the ET tube if present while you're looking to establish an IV or an IO if one's not already present. So unlike older children and adults, neonate arrest is often rarely due to hypovolemia. So aggressive fluid resuscitation is rarely a priority in these age groups unless significant blood loss is present. So in these cases here, we just talked about the epinephrine dose and our approach with that there. In fluid resuscitation, we're going to start with a fluid bolus of 10 mils per kilo. We're going to give that over 10 minutes per our protocol. I do want to caution you that this needs to be administered at a very slow rate. This potentiates the preterm newborn to intraventricular hemorrhage as their vasculature is quite fragile. So 10 mils per kilo, 10 minutes at a very slow rate. The temptation here, because the volume will be so small, will be just to push it pretty quick. So if your newborn's failing to improve, we want you to work through this DOPE mnemonic. Check your displacement of any type of airway that's been established, may need to be removed and replaced. Look for any type of airway obstruction that may be in place that needs to be suctioned. You can evaluate for a pneumothorax. This is done by illuminating the chest with a flashlight. Be cautious. We don't want you using your LED flashlights that put off enough heat to fry eggs. So just be cautious with that, illuminating that. And we'll discuss, treatment of pneumothorax and how to decompress that in a skills lab. Equipment failure, definitely make sure you're checking your stuff. So remember that DOPE mnemonic: displacement, obstruction, pneumothorax, and equipment failure. Next, we want to use the stable mnemonic to help you remember the targets of resuscitation. So sugar, temperature, airway, breathing, labs. Here we're talking about end-tidal CO2, and there's some emotional support for the family. So with that sugar, we definitely want to consider within the first 30 minutes of birth, we want to avoid hypoglycemia. So checking that sugar is going to be important. You carry D10. It's going to be a 2 mil per kilo slow IVIO bolus of D10 for those hypoglycemic babies. So definitely make sure that we've checked that sugar within 30 minutes of the process. So putting this all together, let's go back to our goals. Warm, pink, and sweet. That is ultimately what we want to achieve. Remember, hypothermia is not allowed. Increased mortality, increased morbidity, difficult to resuscitate a cold baby. Keep them warm. Ventilation is going to occur, if that's all that's required, at 40 to 60, just enough to make that chest rise. Airway position is going to be important, and we only suction if the airway is obstructed. Remember that preductal sat? That's which hand? That's the right hand, okay? Understand that it will climb. It's going to start at about 60, and about every minute thereafter should climb by at least 5. And by the 10-minute mark, you should be in that 90 to 95% range. Your 3 lead, optimal in capturing your heart rate and monitoring that. Advanced airway before compressions. You got 40 seconds to get it, no pressure there. But remember, get that advanced airway before compressions to assure adequate ventilation, because that's the key to addressing heart rate. Coordinated chest compressions at 120 events per minute. Remember that 3-to-1 ratio, that 1 and 2 and 3 and breathe. That'll get you there. You have your meds, which is your epi, your fluids, your D10. Remember, fluids isn't always necessary and are only truly indicated if you suspect severe blood loss from mom, from say a placenta previa or an abruption, where baby blood loss may also have occurred. Mr. SOPA is good in identifying any type of ventilation management issues. DOPE, if things aren't improving, go through that, and remember stable to keep things that way. If you have any questions, put them in your post-presentation evaluation, and they will be addressed, or you can shoot me an email direct, dhowerton@medstar911.org. I appreciate your time, your patience, your attention, and we look forward to working with you down the road. Thank you very much. Have a great day.